Oh, there's still more. Can you admit more? Hey, can you plug your mouse into it? Do you have time? No. We just may have to go up there and admit more during that. You can see the top. This? Quite a amount of people. Take care. Hi, everyone. If you could mute yourself before we get started so we don't have any background noise. We'll give it a couple minutes to allow people to hop on. All right.
Is everybody in?
Yep, we should begin.
So the dark is if you want to call in?
Yeah, or they just turn the camera on. I see. All right, we'll give it a few more seconds and then we will get started. Oh, you know what? Do we want people to hear him? Here, he can unmute himself. Mike can. Mike, are you able to unmute yourself?
Yes.
Okay, perfect. All right, well, Mike, if you want to get started and speak and then mute yourself after so you don't have background noise. Thanks for having us.
Certainly. Thank you all for being here today. This is a presentation that is being presented in part through Vine Faith in Action, and we appreciate all of the great panelists who are here for us today because it's as always a topic that's out there that needs to be talked about so that people can understand what's happening. So I am just going to step aside and Laura, let you and your folks take over.
All right, perfect. We'll just give you guys all a heads up. Just make sure you stay muted. We have you all muted for now. And we'd ask for you guys to just keep your questions until the end. We'll allow plenty of time for that. And just excuse us if someone's leaving the table to go admit somebody, because we have our computer kind of far away from us, so you can get all three of us in one camera shot. So I'll introduce myself. My name is Laura, and I'm a care transition coordinator with St. Croix Hospice. Today with me, I have Kelly from Adara Home Health and Jen from Freedom Home Care. So today we're going to talk about each of our individual services as well as how we can work together. And like I said, we'll allow some time at the end for you guys to ask any personal questions. And you guys can always contact us. I think Mike has our contact information if you guys do want to reach out and ask any more personal questions or set up a more individual meeting. So I will start off, I'm with St. Croix Hospice. So we provide hospice care here in the Mankato community, as well as throughout Minnesota and in the Midwest. We started, our owner, Heath Bartness, was a nursing home administrator, and he was seeing different hospice agencies coming in and out of his building, and just he wasn't getting that communication and that support that he was really wanting for his patients to receive. And so he started his own hospice company 11 years ago now, and his goal was to get at least 50 patients. I didn't know if that person did. And he surpassed that within the first few months. And so he knew he had something good going on. And we continue to grow and have now covered Minnesota, as well as Wisconsin, Iowa, and several other states. So our main thing is to really provide that quality and personalized care for our patients. All we do is hospice, so that is our main focus. So we're not connected to a hospital or clinic. So our main focus is hospice and providing that quality end of care life. A lot of people ask, where did hospice come from? Hospice came from, it started over in England with Dame Cicely Saunders. And she really saw patients at that time were just kind of pushed back to a back room. Clinical staff, medical staff, and even family weren't really sure how to provide the best care for patients at the end of life. And so they were kind of just pushed back to a room and kind of left there to die. And she just thought there was so much more we could do. And so she started that hospice movement and was able to provide that quality end of life care. We always say when babies come into this world, we celebrate them. And so why shouldn't we do this when our loved ones are leaving as well? So she really started that movement, and then it slowly came over to the United States. A lot of times people will think too with hospice that is only for patients with cancer. And originally, when it came to the United States, it was originally only for patients with cancer. That's the only way it was covered under Medicare. And so if you did have hospice, a lot of times with hospice with cancer, you did die more quickly because you were doing all those preventative treatments until you didn't have any more choices. Since then, we've been able to put a lot more other diagnoses underneath hospice, like COPD, CHF, cancer, dementia, and as well as a combination of failure to thrive and another supporting diagnosis. So there's lots of different ways that we are able to get patients under hospice and really provide that end-of-life care. Hospice recognizes dying as part of the normal process of living, and our goal is to maintain that quality of life. So rather having those ups and downs and rehospitalizations, our hope is to kind of keep our patients more stable, comfortable, and maintain that quality of life. So what does hospice all include? Hospice is going to include the services that our team can provide, any medications that we see necessary for our individual patient, any equipment, as well as any supplies that they may need. So that might be a hospital bed, a wheelchair, bedside commode, pain medications, incontinent products. It really depends on the patient. When we're evaluating our patients, we're really looking at them individually and seeing what the best route is for them, and that care plan may change day to day, week to week for each one of our patients. So what we do for one patient is not what we do for the next. And what we do in one community is not always what we do in the next either, because each community or home or patient has different wants and needs. And so we recognize that and want to be able to meet them where they're at. We also are available 24/7. So weekends, holidays, late nights, we are available to send our nurse out. So we may be, upon admission, maybe doing 2 to 3 visits a week, but then we go up to daily. And then if something happens while we're not there, we would send our nurse out if needed or talk about things over the phone. We're also going to provide that choice too. So a lot of times people get worried that by bringing in hospice, that they may not have any more choice to make anymore, that we're going to be making those choices and they're just going to continue to move on with life until that last day comes. And we always provide choice. So we'll always educate our families and our patients on what recommendations we make, but you have that ultimate decision to say yes or no. So I always tell families that you guys are steering the ship and we're there to guide you. We don't always know which way the river is going to take us, but we're there to kind of support you and hold your hand during that time. Not only are we going to be providing that medical care for our patients, we're also going to be providing that spiritual and emotional support as well. So on our team, we have our RN case manager, our aide, social worker, chaplain, PT, speech therapy, and occupational therapy. And that's more for using when learning to use new equipment that they may need, or to evaluate, do a swallow study to look at what's the best food for them to eat. Then we also have our nurse practitioner and our primary physician, as well as volunteers and bereavement support as well. So we will provide bereavement support for 13 months after our patients pass away to really get past those holidays, anniversaries, and other major events that our families or loved ones may be experiencing after our loved one passes. We can provide hospice wherever they call home. So whether that is in your own home, an assisted living, nursing home, there are some hospice homes that we are able to provide care in as well. We can provide in Rochester, we've provided in hotels if they're not able to go home. So really the options are endless. As long as our patient is safe and comfortable, that's where we want to provide that care. So I know we talked about some eligibility indicators and diagnoses for hospice, but the big thing is, as long as they always say 6 months or less, the doctors would say. Well, if we were to take the specific disease, if we were to take its natural progression, the patient would pass within 6 months or less. No one really knows how long a patient has. We don't have a crystal ball. So it's really just meeting that patient where it's at. And as long as they continue to show that decline, we're able to reinsert them and continue them on hospice. We have patients that have been on for a couple of months, We've had a patient recently that died that's been on for a couple of years. So nobody really knows, and our goal is to just really keep that patient comfortable forever, how long they have. So indicators could be weight loss, increased hospitalizations, falls, loss of appetite, no longer eating, weight increase or decrease. There's lots of indicators that can bring on hospice. I also, before I end, I just wanted to kind of go through some myths that a lot of people bring up or ask regularly in regards to hospice. A lot of times people ask, so if I'm at a facility, what more can hospice do for us? Hospice is not there to replace the care at a facility, so you will continue to get that care that you're being provided. We will just provide care on top of what you're already receiving. So we're there to complement it. So when we're there to provide that care just for you. So we may be there for an hour, a couple times a week, and our focus is just with you. So we're not paying attention to the other patients at that time. We may take over a bath. Let's say you have a few baths in a week, we'll replace one of those. We may assist with meals, different things, go for a walk. So you'll continue to get what the facilities provide, and then we'll provide care on top of that. A lot of times people ask too, well, if I get on hospice, will I die more quickly? Studies have actually shown with the help of hospice, patients tend to live 29 days longer while on hospice compared to someone that's not on hospice. Why, you may ask that, is because we're reducing those rehospitalizations, we're keeping those infections at bay or treating them as they arise, and we're just really keeping that patient comfortable and making sure those pain symptoms and any other symptoms are managed and taken care of. A lot of times people ask too, how much is this going to cost me? I don't know if I can afford an additional service. Well, fortunately, hospice is 100% covered by Medicare. So all services that we provide, equipment, medication, and supply, or anything else that we deem necessary for the patient, for their diagnosis, Medicare will cover that at 100%. And if you don't have Medicare, a lot of private insurances will also cover hospice as well. And we will help you get that information before we ever admit you. So don't ever feel like you are going to be billed for services we'll make sure you're aware before we start billing for those services. We talked about it's not only for cancer, there's lots of other diagnoses that you can qualify for under hospice. Another one is DNR. A lot of times people think that you can't go on hospice if you are full code and still want life-saving measures. You can continue to be full code. We'll just continue to educate you on why maybe by switching to DNR, it may be a better choice for you and your well-being. So those are just some myths. And so now I will hand it off to Kelly with Adara Home Health, and she'll explain the services that she can provide. Thanks.
Thanks, Laura. Before I start, I need to say hi to those of you in the Parkinson's education program. I miss you. I hope you're doing really well. It's nice to see a few of you. I'm Kelly, as Laura said, from Adara Home Health. And so some of you might remember Adara as Prairie River Home Care. So we changed our name in 2019, thinking that it is a better reflection of our mission. So Adara means with regard, respect, and honor. And that's how we like to approach our care. So Adara is a family-owned, Medicare-certified agency. So that means that we provide skilled nursing, physical therapy, occupational therapy, speech therapy, as well as home health aides to provide hands-on care. So we have 8 branches throughout 60 counties in Minnesota. The Mankato branch recently merged with the Fairmont office. So we are your go-to for Mankato and surrounding communities for home health needs. So we work most often with people who are getting discharged from a hospital or a rehab stay. Those in assisted living communities that are showing a bit of decline to keep them as independent as possible. And we do receive a significant amount of referrals from clinics and from just straight individual families and caregivers. So we'll discuss at the end how home health, hospice, and home care all kind of work together and how we make referrals between the 3 of us. So how I'm going to talk about our services is go through the 5 most common questions I get asked. And the very first one, of course, is what will I be charged? So Medicare covers home health 100% for a qualifying event. Outpatient Medicare, so if you were going outpatient for your physical therapy, is generally covered 80% and oftentimes involves a co-payment. So we do take other payer sources like a VA, MA, waivered services, county services, and private insurance. So individual plans vary, but we work with you and your provider to help understand what your individual coverage would look like. The second question I hear a lot is, how often will somebody come and for how long? So first of all, care is always individualized. So you will work with your case manager to develop a care plan that best meets the recommendations and what you're looking for. So generally, skilled nursing is dependent on the specific need. So if someone's looking for a medication setup, they could come once a week or once every other week, once a month. We do a lot of wound care. So people aren't having to go to the wound care clinic. We can actually come to the home and redress that wound and keep an eye on it. And that would be, again, kind of as often as needed. We often see that about once a week. And then we do provide catheter care. Those are generally once a month nurse visits. If you're looking at therapy services like the physical, occupational, and speech, they come out about 2 to 3 times a week for about an hour. And the whole episode lasts generally 6 to 8 weeks. How do I qualify for a Medicare episode? Well, the biggest thing that Medicare is looking for home health is the homebound status. And so that doesn't mean that you're homebound forever. It just means that you're homebound during this time. So you got released from a rehab stay and you're weak and tired and can't go out by yourself, you would be homebound. And then once you have gotten back to a more standard level, then you transition to outpatient. Right now, Medicare is allowing it to be a lot easier to qualify for homebound status. They're saying that anyone who is at greater risk for COVID can be considered homebound. So, I mean, for over 65, you're already in a category of being at greater risk for complications. So right now they are qualifying most for homebound. So if you're going to outpatient for anything, wound care, therapy, you could consider transitioning to home care. So what can a home health aide do? So we will send home health aides, and it's covered during a Medicare episode. So if you have the skilled nursing or physical therapy, you can also have a home health aide come out a couple of times a week and assist with showers or dressing. They don't do things like meal prep or running errands or any kind of cleaning. And Jen from Freedom will talk more about that. We see that more often in private paid home care services. So we can work together with them. We'll talk about that a bit more. You could have both at the same time. So the last thing we hear is, what information do you need to get started? So there's a couple ways to do it. If you're just at home and you are a caregiver or an individual and you're having some increased difficulty getting around your house or falls or balance, you could just call the office and we'd walk you through the process. So at the end of it, we need basic demographic information and a doctor's order. So there's a couple ways you can get a doctor's order. You can see them face to face and request that, and they can send it over to us, or we could make that request and then we'd set up a virtual appointment because Medicare says you need to be seen by a doctor, but we could do that virtually. We've helped facilitate that for many people. And then we just get it scheduled. So it's pretty simple to get the information needed, and it's just a phone call straight to our office. That's all I have. So I'm going to hand it over to Jen with Freedom Home Care, and she'll talk about the private pay piece. And then Laura will give some examples of how we work together and can make referrals between the three of us.
Hi, I'm Jen from Freedom Home Care, as Kelly stated, and I just wanted to talk a little bit about what we do here as well. we provide one-on-one care for individuals who are in their homes. A home does not have to be in their own house. It can also be in one of the communities, in any assisted living, memory units, independent facilities that we can go into as well. We want our clients to be able to retain their independence and have a high quality of life. We've been in business for 6 years. We opened our doors in 2014, and we started with a basic license, and then we moved on to our comprehensive, where we are able to help with personal cares, dressing, bathing, personal hygiene. We can help with people that are incontinent, help with hearing aids, denture cleaning, those type of personal cares. And with our clients, we have a nurse that would oversee them. We have 3 great nurses. We also have a social worker as well. And then we just started having a new caregiver mentor, and she started about 2 weeks ago. She is going to be kind of like a liaison between the client and the client family, and then also with our caregivers. So she is doing training, she's going out doing introductions, and she's just making sure that everything flows just as we would like it to be. We can also assist with transfers and assisting with ambulation, helping people get out of bed in the morning, helping us assist with the toilet assist, and then medication setups, reminders, and administration. Our nurses can go out and they can help set up medications. We know it can be cumbersome when you're going to the doctor. Now you've got a new prescription, or you don't know what each pill is and how often. So our nurses can set up those medications. And then our caregivers are able to also assist in administering them, especially when it comes to our hospice clients. We can do that administration piece with them at that point. We provide light housekeeping, like laundry, cleaning the kitchen areas, vacuuming, sweeping, mopping, and then we can also do meal preparation. And like I said, we've got our mentor that is assisting with helping those people. So if we have a caregiver in the home and she maybe doesn't know how to cook a meatloaf, we can help her learn how to do that, getting her recipes, talking to the clients about, do they have a family recipe that they like. We are also able to do transportation to appointments and go shopping, run errands. So with that homebound piece that Kelly had discussed, we can go to the grocery store for that person and we can pick up the items that they want. Or if they have that follow-up doctor's appointment after their rehab, we can give them a ride to the rehab appointment then. And then we accept long-term care insurance. A lot of people will have long-term care, but not really know much about it. What does it cover? They think it only covers if they live in a nursing home. Well, long-term care has changed through the years, where they're seeing a lot more people wanting to live at home. So they're accepting the long-term care with home care instead of just with living in a facility. And so you would still have that elimination period, and that's where it's great for us to come in. And we can do a free consultation, talk to you, read through your policy, let you know when a good time to start, how to make the best use of that plan as well. And then our case management program we have, where our case managers are either a social worker or a nurse. They will help with bringing our clients to doctor's appointments. They will go into the doctor appointment as well, hear what the doctor has to say, take notes, and then let the family members know. With COVID, a lot of people cannot get into facilities to go to that doctor's appointment that maybe is in their facility. Bluestone comes in to visit with their family member. Well, we can go in and we can be there during that appointment, and then we can report back. We are that advocate for those families that are out of town. We've had people that have lived out of the country and their mother was on hospice, and when she had passed, the daughter had no way to get back home to be able to pack up her apartment. So not only do our caregivers help the daughter with her mother and be there during those final days with her, but then they were also able to go back and help pack up the apartment and get things put into storage for her. And then we can do hospital visits and discharge planning. We meet with the rehabs, case managers, and over at the hospital. and we follow through with them. What's happening with the client? What are they expecting when they go home? Do they have other services that are coming in that we would coordinate with them? And then we would make sure that whatever the plan is set, that we would follow through with that when they go home, to make sure that all of their services are being carried through and they've got that continuum of care. And overall, we'll go through this in a minute here, but working together as a team, we're going to discuss that on how we can supplement each other, how we all work together, that is a good cohesive partnership.
I just want to say a couple of clarifying things about home health and home care. So home health is that Medicare covered, as I mentioned, and then home care is private paid.
Yes.
So there would be situations where you could use both. So let's say you're getting a Medicare episode, but you need additional cares that maybe are not hands-on, that Medicare's not covering, then Freedom would bring in the aid to supplement that. And then also when the episode ends and things aren't covered and you still want an aid to come in, Freedom would take that over. So that is, we do that pretty frequently, actually, working together. Or if you had Freedom in for private pay and they're noticing some decline, then we could come in and work with some therapy needs. So it really is, we have lots of examples where that has really worked very well collaboratively to keep people in their homes independent and kind of being able to access all the services that they qualify for. And Laura will give some other examples on how the three of us can refer back and forth and work together.
Yeah, so we kind of created the home care crew, and so how we can work together. And we have a little flyer about different scenarios. So one is you're not ready for hospice. So when a patient does not qualify for hospice or has chosen not to take the hospice route at this time, there still has likely been a change in their condition, which most likely qualifies them for home health, nursing, or the therapy with Adara. So if we have a patient that's just not ready, they obviously have had that decline, and so we can refer them with the patient's okay over to Adara, and Adara can come and do an evaluation and keep them home. And when that time does happen and they are wanting to go on hospice, they can give us a call and we can kind of start there as well. Home care can also fill in on those care needs. So if a patient's still not, like Kelly had said before, if they still need more assistance on top of what the home health is already providing, Freedom Home Care can also provide care to fill in those need gaps and provide services to help both the primary caregiver as well as in a facility. There also is sometimes when we have patients that graduate from hospice due to they're doing well, we've met their needs and they just aren't, that decline isn't happening anymore. Maybe there was an episode that they started to decline, they had a fall, or they came back from rehab and they just were declining. Once they start doing better, we may graduate them from hospice. So rather than our services abrupting quickly or discontinuing, it may be important to consider both Freedom Home Care as well as home health, nursing and physical or occupational therapy to continue to regain that strength and independence as you continue to do better. Kelly had already mentioned if their home health services with Adara are ending, it may be a good idea to consider a referral to Freedom Home Care with Jen to alleviate that stress from the primary caregiver and ensure that continued safety in their home. If those home care services aren't enough with Freedom Home Care, then it may be good to look back to at Kelly and ask for a home health assessment to identify qualifying nursing or therapy needs per individual. Also, on top of those, due to continued decline, despite home health's involvement and home care services, you may look into a hospice assessment to determine if they would qualify for even more additional services. So when these services kind of all work together, patient is more likely to have qualifying needs identified, and they're able to remain safe in their home and have less hospitalization, and close that. And we're hoping to close that communication and service gaps, which will ensure that total continuum of care and to continue. So you can really continue to stay with one of our services throughout your end of life care, no matter kind of where you're at with your health. So I just wanted to open up to questions. So who wants to start us off with a question? You can use in the chat box or you can unmute yourself.
Well, I'll start. I'm Joyce, and I'm on staff at Zoom. I'm on staff at Vine. And first of all, thank you, all three of you. And Laura, I know that you kind of coordinated this, and so I'm really happy to meet you, Kelly, and you, Jen. And I've had really good experiences with all three of your organizations, and also good feedback from caregivers who have accessed your services. So thanks to all of you. One of my questions is, how would you suggest that caregivers make a choice in terms of the various agencies that are available for both hospice and home health, home care, or all three of those, I should say?
Yeah. I would recommend, so I know we had talked about choice a little bit, but you have freedom of choice for each individual company. So there are multiple home health agencies, multiple hospice and home care agencies in the area. So I always encourage family members to maybe do a quick Google search to see what agencies are available in the area and take that time to interview them. Each company is different. They have different philosophies of care, different services they can provide. And what works for you may not work for your friend. So each family has different wants and needs. And so it's always important to take that time to interview the companies before you make that decision. I don't know if you guys have anything to add.
Sure. Yeah, and just another note too, there's been times that, you know, if I've gone to an appointment and I've done a consultation with somebody for home care, and I see that they have a need for hospice or maybe home health, that I've been able to talk to them, give them the option, and then let's say they decide to go with one of these two ladies, then I would give them a call, let them know what's happening, and then they could follow up to see if they would qualify for one of those with either hospice or home health. So we're all three well versed in each other's companies, that if one of us were in consulting you on it and you had a question, they would be able to answer what we could do as well.
Mm-hmm. And I would say a few questions that I'd recommend when you're calling any agency would be to ask how long they've been open. Oftentimes, especially with home health and home care, agencies will kind of pop up and then disappear within a year. So you really want to look for somebody that's been around for a good amount of time. I would ask for references. Most of us have references of clients that we've worked with, and they can share some information about what their experience has been, asking about how their 24-hour call system works and who would be available and what that availability really looks like on a 24-hour basis. And another big question I would ask is about turnover. You know, if you're seeing a place where they have nurses and staff that have been with them a long time, that's a very good sign. There's a lot of turnover in healthcare in general. So, you know, asking, you know, how long has your longest nurse been with you? I think that would be a good question. Because like I said, there is turnover in general, so I wouldn't be too surprised to hear that, but you're gonna kind of be able to see the difference if you're seeing nurses stick around for longer periods of time.
And this is Mike, also from Vine. Having been in kind of the position where I had to be a caregiver for my father, I know that there are some times when the caregivers feel it's their responsibility to step in and make these choices. I know that Vine offers classes in 5 Wishes and other things. I'm wondering what you would recommend for the caregiver to have already done before considering the options that you three offer, as far as working with the care receiver, so that you know what the needs are and what the wants and desires are of the care receiver.
Yeah, well, I think I'm understanding your question right. So just talking directly to caregivers about what they need to know when they're accessing any of our services. Yeah, so the first thing I would recommend is to not wait to do that, because I've worked with caregiver support quite a bit. And what I've seen is caregivers getting really burnt out and tired. And then you run the risk of something happening to that primary caregiver. And then what happens to the person you're caring for? Then you're both in trouble. So my experience, and I've done this for many, many years, over 10 years. And my experience is that people wait too long to access services, and they get tired and they put themselves at more risk. So I know that financially that's a hard decision to make. Medicare is covered, so at least you have some benefits there. But it's worth it. If you are not sleeping a full night for any nights of the week, that would be a key that you need to bring in some additional services. Just feeling increased fatigue. At least be exploring your options before you need them. So when you get there and you're already stressed out, and then you're navigating these systems that are new to you, it can be very frustrating. So I know you hear often about planning ahead, and it's kind of the same here. You want to know your resources before you need them, and you want to start using them before you really, really need them. Does that answer your question?
Yeah, and I guess the other part of it was the discussion that the caregiver should have with their parent or whoever they're working with to find the right services for. Because I know in some cases people can be very, I'll say hard-headed, but I don't mean that in a derogatory way. But
Yeah.
they have their own ideas of what they want or feel comfortable with, and I guess that conversation I feel needs to take place before they necessarily come out and make the decision for. Whether it be freedom or, whoever the choice is.
Yes, I've worked with many families before. In the past, I was a manager of a home, and that was the one thing that I would see most frequent. People would come in with their parents and then say, "Hey, mom, dad, we want you to move here," and there was no discussion about it beforehand. It was, mom got into an accident driving. She's not supposed to drive anymore. The doctor says she's not safe at home. Oh no, what do we do? And so that's where I like to have that conversation in the beginning. So even if you don't think like right now, today, we don't need that help, but I say, where was that person 6 months ago? And are they today? Where can they be in 6 months? So if you look back 6 months and think, okay, where were they back in June? What were they like then? And what are they like now? Is there a change? And if there's a change, okay, what can that change be moving forward in the next 6 months? So just thinking about it that way, and then having that conversation where we can come in, we can meet, discuss what the options are. So when that time comes, they're prepared and they know, this is who I want to go with, this is what I want to happen. And it makes it a lot easier for us then, that they're already in that acceptance phase, that they've accepted that, yes, I do need that help. So when we're there, the caregivers aren't being told, no, I don't need any help. I don't know why you're here. You can leave. And then the caregiver comes back feeling really bad, saying, I don't know what to do. I really want to help them, but. And so that's having that conversation right away in the beginning, and then talking about it, not necessarily in every day, but occasionally bringing it up until that time comes that you do need it. And there's been times that I visited people and 2 years later they sign up for services because that was when they were ready. But they had that information 2 years ago. So by the time they're at that point, now they know what they need.
Yeah, and I'm gonna just build on that, having that plan ahead and having the assessment come in. All of us do free assessments. Mm-hmm. We do a free care needs assessment through Mankato Clinic. And so then we can come in, and it's not that we're starting services. We tell you, these are what you qualify for, and it's up to you to do it. So again, like we talked about before, knowing that information before you need it. Nobody wants to lose their independence. I say all the time, nobody wants to use any of our services at the end of the day. Yeah. You're not like eager to make this happen. So knowing what your options are when you don't need it and you're not feeling defensive, you can be more open and receptive. So if you're a caregiver and you're knowing that at eventually some point I'm going to need this, having them meet the people, like Jen said, 2 years earlier, Here are your options. Here's potentially what you would qualify for. Then when that time comes, then you give them a choice. We need to do something here. What do you want to do?
All right, thank you.
Any other questions?
I would just add, from what the two of you have shared, that was my experience when I was a hospice chaplain as well, is that it's so important to know about hospice and perhaps even to do some education with your care receiver and family members about what hospice is, so that the person who will need hospice or may need hospice at some point, that it's not a case where it's 2 days, they're on hospice for 2 days or even 24 hours. It's so much better if the individual can have a relationship with the hospice team than to just have hospice come in at the very, very end. And hospice can be such a support to the entire family. So just another push for learning about these services earlier than later.
Yeah, and and like Laura was talking to about the graduating, we have a client that was on hospice 4 years ago when we started services. And because we had hospice in regulating her medications, we had people in the home making sure she was getting nutritious meals, her oxygen levels were set. She's still with us today. She graduated off of hospice, and because we had the continuum of care where we were still in there, she is still with us, and she's just going strong today, 4 years later.
I have a question for Adara.
Yeah.
We have used you in the past. It was over a year ago, and my husband needs some more therapy, and physical and speech. He is also a veteran. Do we need to contact the VA or can we contact you directly?
You can contact us directly. A lot of times with VA services, he would still qualify for a Medicare episode. So we would do that under a Medicare episode that usually gets started a little faster than VA moves. And then if he needs things longer term, VA does provide that. So then we switch him over to that. So you could just call our office directly and speak to Lindsay. She's in our intake.
Speak to whom?
Her name is Lindsay. She's our intake coordinator.
Okay. All right, thank you.
You're welcome.
My mom is in a independent living facility in North Iowa, and our family decided about 3 years ago that she could benefit from home health care. So one of our goals was to try to keep mom in this independent facility as long as possible. And so we talked with her about the local, it's a small community, but there are some local agencies that do home health. And I know that mom is only in that facility to this day because she gets daily home health, 7 days a week. So that has been a real gift for her and to our family, especially now during COVID, because we are able to visit her where we would not be if she was in an assisted or skilled care facility. And I know not every independent facility allows visitors, but this particular one does. Especially if we have limited it to just one family member. I do wonder though, before you mentioned that you also provide services in assisted living
Yes.
facilities. So why would a care receiver need additional care in an assisted living or skilled care facility? Because
Well, even
that.
in assisted living, they're not having someone with them or right by them 24/7. So the most common thing we see in assisted living would be a fall. If they had a fall or balance issues or near falls, then we go in and do the physical and occupational therapy. Even in a dementia unit, they see a lot of issues with speech and swallowing. That would be a speech therapy referral. Sometimes if they don't want to pay for all the medication and the catheter care because they have different packages in assisted livings, they choose to use us. And then some of those things are covered. So the assisted living isn't a Medicare certified company. So they're not covering a catheter change where Medicare would. And same with wound care services, that would be a charge from the assisted living. Whereas if they would qualify for a Medicare episode, it's paid for.
Thank you.
You're welcome.
Any other questions?
And as Laura mentioned, if you have questions that you just didn't want to ask in an open forum like this, feel free to contact me or them directly if you have other questions, because I know sometimes this is a good general information gathering point, but not where you want to necessarily talk about personal issues. So please feel free to make that contact on your own.
Yeah. Will you be sharing our contact information to the group? Do you have all that?
I'm sure I can get it. If I don't have it, I will get it and share it. We will also be, I've talked to Laura about getting the video for this and posting it on our Vine page. We've got a page that's called Virtual Vine, where we've been posting these Zoom presentations that we've done. And I will see about getting the information out that way as well.
Perfect.
And I can assure you that whenever our coaches do intake visits, if people, as we continue to do coaching with caregivers, we are constantly giving out your brochures and other information about each of your agencies. So Mike, that information is right out on our flyer board next to Adam's office. Okay.
I have a question. This is Betsy Paul. Is it coming through?
Yep.
Yeah, hi, Betsy.
Okay, great. Hi. I have a question. I've worked in home health for a number of years. I've now retired, but one of the questions that always comes up is about Minnesota and the bad weather. So how do you ask a home care agency, you talked about asking about their staffing. What is a good way to ask about how do you handle when the roads are too bad for the caregiver to get there? Or, what do you say to the family under those circumstances?
No miracle answer to that, but for all our services, right in there, the backup, there is a family member identified as a backup. We have to have some kind of, so it's the main person, and then if there's someone closer, we try to cover staffing if there's someone closer, but we do always say a family member has to be identified as a backup. And that is a real concern, especially in our rural communities when that happens. And planning ahead, if we can change, we see a storm coming and we see that they need a visit, switching the day of that. So they do quite a bit of trying to pay attention to that and manage that. But the primary family person is always designated as a backup.
Yeah, and we do the same thing as well. That's the joke in the office was there were 3 storms last year and I was on call during all 3. And so that's how it felt. But what we did was, we started watching the news. We knew that the snowstorms were coming. So there was one particular storm in January that was on the weekend. It hit like Friday afternoon and it didn't stop until Saturday evening. So we have some clients that have 24-hour care. Now, that doesn't necessarily mean one person is there 24 hours. It might be 2 6s and then a 12. So what we did was we called some people and said, would you be willing to stay the 24-hour shift and then work Friday until Sunday? So we knew, okay, that person was covered. And then we were able to take those few people and then move them someplace else. And we did a lot of rearranging visits to try to get people to stay as close as they could to their home. And then we call the clients to let them know this caregiver is changing. We just want to let you know it's not going to be a regular person, but this is how we can do it so you still have somebody to see you. And then we do also triage our clients as well. You know, people like Kelly had said, identify that they have a family member. We do have some people that don't have family. So they're going to be the ones that we're going to make sure that are staffed first. And then we're going to work our way down to those that do have a backup plan.
Yeah, we prioritize them. They're given, I don't know exactly what it looks like, but the people that are critical have to be seen. They are identified at intake. So they're given, you know, a priority number.
Yeah.
So then, you know, if it's a critical care, we figure out a way to get there.
Yeah.
For some of those nursing needs, obviously.
Yeah. Well, thank you. And I know that COVID has also added an extra layer of that with staff having to stay home with their kids and stuff like that too. So thank you for your work.
Thank you.
Nice to see you, Betsy.
Good to see you, Kelly.
Anybody else have anything they want to ask, even if it's through the chat? If you do that, I can ask the question for you anonymously. That chat feature, of course, is at the bottom of the screen. You just click on that and type in your question. Otherwise, I don't know if you talked about this at all, but what is the is there an increase in each of your services that are being provided as people become more aware of it? And I would guess as they become aware that Medicare will cover the service, that's got to be a great weight off of a lot of families' minds as they consider what's right for their family member.
Yeah, it's constant education, I think, for all of us, because even primary caregivers like doctors don't understand our services. I've been very surprised sometimes when I've talked to other professionals. And they're like, oh, I didn't know that was covered. So it's really continued educations like this and getting the word out, not only to community members, but to other professionals in our community. And for home care and all our services, just with COVID, I think we've all seen an uptick in services and people not wanting to go to hospital or rehabs or even to their clinic appointments, and that Medicare has allowed the homebound status to be less stringent. We had the busiest summer we've ever had, and we continue to be busier than normal every month right now.
Yeah, and with us, we're seeing our case management services go on the rise because people aren't able to go into the facilities to be with their families. And, you know, we've got some people that call and say, my mom is lonely, she needs somebody to be with her. And so our case managers, they would go in, bring her, you know, something that she, you know, her snacks, take her for a walk, bring her to her appointments, hair appointments. So we've been seeing a rise in those, and then as well as our caregivers too. But I would say the case management portion has really greatly increased into the facilities. And then we're seeing the caregivers rise with people that are home that are afraid to go into a facility right now.
Yeah, that communication is huge, that we are all still thankfully able to go into these buildings and communities. And so by having that communication, in addition, because the staff at the facility, they are running low staffed, they're busy, there's COVID in their buildings. They don't always have the time to communicate with family weekly or a couple times a week. And so when we're able to go in and provide that communication for family, that family satisfaction, as well as the patient satisfaction is huge. And we're all able to also help with, at least I know St. Croix, with virtual visits with families too, via iPad or the phone, whatever is possible.
So in a very kind of sad way, this has been a way for people to understand the value that is added by going through your services.
Yes.
Yes.
All right. Well, I have not seen any chats. I know that Joyce wanted to mention something before we go, and I wanted to mention too that that Vine, we've been doing a lot of different programs through Zoom, and we actually have one coming up on this Thursday that's talking to folks from the MSU. I think it's their speech. I don't know if it's speech pathology, but talking about Parkinson's disease and how it affects communication amongst the patients. So there's still an opportunity for that. That's a 2:00 program as well. So if anybody would like to please feel free to contact us at Vine. And Joyce,
thank
did
you
you?
guys, yeah, and thank you guys for all you guys do too in providing these resources for the community. It's huge.
Thank you.
You're welcome. A couple just a couple things I want to share regarding caregivers. Yeah, this month is National Caregiving Month. So just kudos to those of you who are caregivers on a day-to-day basis, 24/7. We know that this is difficult and very, very exhausting work. So another program that's coming up, it was rescheduled, is a program that Mayo Health System, four members of Mayo Health System team are going to do a presentation on December 3rd at 2 p.m. It'll be a Zoom facilitated again by Mike. And it's just, I think they're going to make it really fun. They're going to talk about food preparation, exercise. It's all about the caregiver, this particular Zoom. So we would encourage you to register for that at 2 o'clock, December 3rd. Secondly, we want you to know that we offer caregiver support groups through Vine. I do a rural group in Mapleton once a month on the first Tuesday. If you'd like more information about that, please call Mike and he can give you that information. And then we have a virtual support group at Vine on the 2nd and 4th Wednesday of each month. And that one is facilitated by Carol Reese and Mary Wichtendahl. And again, Mike can give you the definite information about that. Also, there are some of us on the team who do coaching for caregivers. And so again, if you're just wanting support and somebody to talk to about specific issues that have come up for you as a caregiver, please give us a call at Vine, and Carol, Mary, or I will talk with you. And also we could facilitate a family meeting if that would be important for you to have. I'm thinking of a particular caregiver I know who is in her late 80s, caring for her husband in his 90s. They both still live at home. Right now, she has no services coming in the home. Family thinks everything is just peachy, but honestly, it's not. And I've been encouraging her to get her adult kids together. And if she wants some help with that, to call Vine, and one of us can do a family meeting. Sometimes it just takes the weight off the caregiver to have a third person, an objective person in the room to help facilitate those kinds of difficult decisions. So those are some things, and I'm so grateful that I could be part of this today. Thanks to you, Laura, and Kelly and Jen. And I want to say a special hi to Paula Mintz and Jack Rupert. I see you're here. And anyone else, Mary, I know you too. If I haven't met others of you, so glad you joined us.
Yeah, so please, if you've got any questions after this, if this has brought some things to the forefront that you hadn't thought of before, please feel free to reach out to any of us here. As we say, we'll get that information out, and you can review this. Maybe this would be a nice way to review this with family members to help get the conversation started. So that will be on our Vine page, and it'll be there for as long as we can keep it up there. So probably months into the future. But thank you to our presenters today. You did a wonderful job of putting out the information that people need to know when they're making these important decisions about caregiving for loved ones. And I want to thank each of you for contributing today.
Yeah, thank you.
All right, and Laura, was there anything else that you?
No, I think that's it. So I will end the meeting and stop the recording and get that over to you as soon as I can figure that out.
Okay, yeah, that sounds good. I'll drop you an email. I've got a way that we've used it before. So.
Okay, perfect. Thank you.
Did I hear somebody else with a question?
I just said, thanks, Mike.
Oh, okay. All right. Well, thank you, everybody. Have a great day.
Thanks.
Bye.